mostly the feeling of fullness, some pain abdomen, headache, fatigue, exertional dyspnea, and cough and sputum. Mind you, this is the data which is from China. And then they followed them up around 1,700 people for another 6 months. And, most of them were men. And most common symptoms. Now, the difference, if you see, in the patients who were followed up at 3 months, they had symptoms related to GI, headache, and then there was fatigue. Whereas when you go on to the 6 month follow up, you'd find that fatigue was the most common symptom. It is the fatigue and muscle weakness, followed by sleeping difficulties, anxiety, and depression. So, what does it convey to us? It conveys that in the first 3 months, you have symptoms attributable to some organ system, but later on, they become more generalized kind of symptoms, or more non-specific symptoms like fatigue, some sleep disturbances, some anxiety and depression. Now, this is another kind of representation where you see that out of 1,700 people, some of them, around 22%, also reported hair loss. 11% reported persistent of smell disorder. Palpitations, which we have seen quite commonly even in our some subgroup of patients who are coming to us on follow-up with us. And then you have joint pains. Other symptoms are decreased appetite, some persisting diarrhea, vomiting, difficulty in swallowing, myalgias, and some of them, less than 1%, complained of low-grade fever. Uh, Now, if you look at the respiratory symptoms, you'll find that almost 95% of these patients had at least one abnormality on CT scan. Persistence of ground glass opacity and irregular lines was common. And around 11% patients had a total lung capacity which was low, less than 80% predicted, and around 20% patients had diffusion problems, DLCO less than 80% predicted. Now this all data which I had discussed till now was all from China on follow-up at 3 months and 6 months. This is the AIMS data. This is one of the papers which had come to me for review. This is a couple of months ago. This was from AIMS Delhi, around 251 patients, more than 2 months after they were discharged. And nearly 13% patient had musculoskeletal complaints, around 8% had upper respiratory tract symptoms, and around 7% had fatigue. The symptoms more likely to persist after 28 days were arthralgias, fatigue, and myalgias. Since we all know that COVID is a multi-system disease. Now, we all are kind of dissuaded by the respiratory involvement and cough and breathlessness, and our entire attention is focused on cough and breathlessness. But if there is a virus there, and if there is an inflammatory response, that inflammatory response involves all the organs. It's a generalized inflammatory response, and it will also affect your muscles, your heart, your kidneys, your brain, every part of your body. And it presents in a post-COVID recovery phase with a variety of manifestations. Now, most common persistent symptoms, as we already seen, are fatigue, dyspnea, and joint pain. This is another study which was published in JAMA. And what is very important is to distinguish between a persistent inflammation, a sequelae of organ damage. Most commonly, these sequelae are seen in lungs, but you may also see these sequelae in heart, and you may also see these sequelae in kidney or muscles. And then they have to be distinguished from the ICU psychosis or psychosis because of or non-specific effects of hospitalization and social isolation. Now, it's very difficult to dissect out the contribution of each one of them. Uh, in many cases, we have seen, and there is enough data which says that the inflammation persists even though the respiratory symptoms improve, the oxygenation improves, and patient gets discharged, the fever disappears, but there is persistent inflammation. As we've already said, there is some sequelae of organ damage, and there is definitely an evidence of psychological overlay. Now, the most common thing, one of my residents who was admitted with us, he had improved, he went home, and he said that for the first 2 weeks, he was not able to get up from the bed, felt that a fatigue which he has never experienced in his life. And I think it is more common in patients who have been very active. They have never kind of lied down in bed. So they get most affected with this. One of the sentence which I can't forget by this resident is, he feels as if there is a tractor which has run over his body. He feels so exhausted. Uh, the most of common symptom is post-exertional malaise, sleep disorder, concentration and cognitive problems, muscle pains, sensitivity to light and developing chills on mild, uh, sensitivity to cold. You have abnormal bloating sensation or nausea, and then you have some non-specific nasal symptoms or throat symptom, persistent of cough, persistence of soreness in throat. Now, the pathogenesis is basically a imposition or superpositioning of chronic viral infection and a dysregulated or polarized humoral or immune response, which leads to a low-grade inflammation, which is in addition affected by the environmental changes. And the most important environmental change which happened in a patient with COVID-19 is social isolation. Now, what are the respiratory issues post-COVID? They are seen mostly in patients who are managed in ICU or HTU and require long-term or prolonged high-flow oxygen therapy. Now, here I would like to bring in another aspect is, some of the researchers have postulated that we've never used very high flows of oxygen to the tune of 60, 70, 80 liters in patients who already have a damaged lung. And some amount of this damage could be induced by the oxygen itself. Again, very difficult to dissect out. As we already said, that in convalescence phase, nearly 50% of the patients do have some abnormal CT findings. Here, I would like to say one more thing is that if you screen asymptomatic patients with HRCTs, you will find some abnormalities in almost 40 to 50% of these patients also. And these scores might range from 4 to 6 out of 22 on a CT scoring system. So the propensity or the insistence of getting a CT scan done to diagnose COVID should be done away with, because if you do a HRCT even in an asymptomatic patient, you may find some amount of ground glassing or some amount of parenchymal changes. Abnormal PFTs are seen in nearly 75% of the patients, and in around 50% of these patients who had severe COVID requiring high flow oxygen had some amount of diffusion problems. Now, this again is a very, very important thing to know. What we've seen is that very many patients require 2 to 3 weeks of hospitalization in an COVID intensive care unit, and then they turn negative. But when even after they turn negative, their virological clearance is there. Their pulmonary recovery takes a pretty long time. We have seen patients who've been with us for 4 to 6 weeks, and they still require low flow oxygen before they can be discharged from the hospital. And the most important thing, the most important symptom is cough. You need adequate hydration. Steam has now been put into question, because steam inhalation has not shown to be very beneficial in taking care of the cough. Drinking warm water and lemon or honey gives you a soothing kind of a feeling in the throat, might not do anything else. The same effect can be achieved by cough lozenges. But the best thing for this is simple breathing control exercises and prevention of reflux. Because when you are lying down most of the times in the bed with the respiratory distress, you may end up getting or exaggerating your reflux. So what you can do as breathing exercise is you breathe in through your nose and kind of make a O with your lips and try to breathe out. Pursed lip breathing, which will increase your lung capacity. Or you breathe in a rectangle. That is, you breathe in shorter and you breathe out longer. That is active in expiration. May not be possible right up front, but slowly work at it and you might be able to achieve it. You can take 2-3 deep breaths, control your or hold your breath, again take 2-3 deep breaths, and then do a rapid huffing, short rapid breathing, which is called huffing. This kind of a huffing, which will increase your lung capacity. You can, if you can lie prone during the active stage, that helps in the diaphragmatic movement. But even post COVID, if you know from the radiology or from your clinical examination which part of the lung is involved, you can keep that part of the lung up by lying on the opposite side, lateral side, and you can drain your upper lobe, middle lobe, or lower lobe and clear the secretions. Now, I won't agree with residual pulmonary fibrosis, because what happens is that you have acute or chronic inflammation, there is epithelial damage, there is pro-inflammatory cytokines, and then there is excessive deposition of collagen. Now, what you see is not fibrosis in true sense. If you have to describe fibrosis, fibrosis in the lung is always associated with a structural change in the parenchyma. That is a bronchiectasis or a cavity or something. What we've seen or learned over a period of last 1.5 years is that you do not see too much of the fibrotic changes. What you see is more like an organizing pneumonia kind of changes, where the collagen deposition which has happened or the damage because of pro-inflammatory cytokine which has happened at the alveolar capillary basement membrane takes a longer time to improve. And very few of these patients go on to develop fibrosis in the true sense. Role of antifibrotics is still under investigation. We at PGI had done, and the best antifibrotics are low-dose steroids. We have done a trial of low-dose steroids in patients who have recovered from COVID active infection and have some amount of a residual organizing pneumonia kind of picture. We're finding very good results with that. But what's happening with that low-dose steroids is that you are able to take care of the organizing pneumonia and patients are not developing fibrosis. So the actual role of the antifibrotics like pirfenidone and nintedanib is really in doubt whether you can really use it upfront or just low dose steroid will help. We don't know what is the drug which is best, duration, and whether there are any biomarkers. So we cannot at this present moment recommend any of the antifibrotics except for low dose steroids to be given under medical supervision to patients who continue to have residual pulmonary symptoms. How do you do a follow-up? You do a chest x-ray. You can do a telephonic consultation always at 4 to 6 weeks of discharge, but at 12 weeks you want them to come over. You want a chest x-ray, you want a pulmonary function test in them, and if that is normal, they can be left on their own. If the x-ray is abnormal, if the pulmonary function tests are abnormal, you can do a high resolution CT and see in them. You ought, and you definitely want to do a clinical assessment at least at 12 weeks. Follow them at 24 weeks and at 6 months, and you can only perform a pulmonary function test. You don't need to do a high resolution CT at every time. And if you find the evidence of persisting fibrosis, development of structural change, then you need to get in touch with your specialists who are there for interstitial fibrosis or interstitial lung disease, and they would need to take care of your patient. If you're still with me, we'll quickly move on to the heart. Heart is the second most common organ which gets affected, and it is the myocarditis or the small vascular micro circulation of the heart which gets affected. If you look at this study published in Circulation, pattern of cardiac disease, you'll find that 30% patients will have normal echo, 16% patients will have LV diastolic dysfunction, which could be because of their pre-existing hypertension or diabetes or any other condition. 10% develop systolic dysfunction, and nearly 40% develop RV dilatation and dysfunction. Here, there is a caveat here that this RV dilatation and dysfunction is not always kind of indicator of a pulmonary embolism. Severe ARDS itself can cause RV dilatation and dysfunction. This is a beautiful study. In 78% patients who have recovered from COVID-19, they did a MR, and they found that 78% of them had ongoing myocardial out of 78% patients, 60% had ongoing myocardial inflammation, which is independent of pre-existing conditions. So what does it tell us? It tells us that the lung recovers, but the heart may take a little longer time, and there might be evidence of persisting inflammation in the lung as well as in the heart. That's not where everything stops. You have conjunctivitis in nearly 89%, cracked lips in 54%, lymphadenopathy in 60%, skin rash in 57%, 30% patients may have neurological function, left ventricular dysfunction in these patients who have multisystem inflammatory syndrome is seen in nearly 100%. So this SARS-CoV-2 related multisystem inflammatory syndrome is a unique entity where shock is dominant, persistent fever and asthenia can be seen in nearly 100% of patients. 80% patients will have digestive involvement, and then you have conjunctivitis and lymphadenopathy or skin rash. In patients who have severe illness, positive test previously and presence of severe inflammation on biomarkers and presence of antibodies to SARS-CoV-2, which indicate that there has been an infection, and now there is persistent inflammatory response. Now, delayed interferon response along with the slow viral clearance happens in patients who have malignancy. Slow viral clearance happens in patients who have other comorbidities like immunosuppressive drugs, chronic kidney disease. They are the ones where there is slow viral clearance. There you may have delayed interferon response. IL-6 and chemokines may increase, and they may lead to a severe disease, include multisystem inflammatory syndrome, which is characterized by shock, fever, and other manifestation related to either gut or the skin and mucous membrane. Now, the interval between this is unclear, although it has been postulated now that it approximately happens in 6 weeks' time. The management is initially you can try aspirin or non-steroidal anti-inflammatory drugs, may or may not need anticoagulation, but in patients who have severe persistent symptoms, a combination of steroids and IVIG has been tried. Vasopressors may be needed for shock or are invariably needed for shock, and in very few patients you may require ventilatory support also. What about psychiatric illness? If this was a study which was published in one of the newspapers, 234 patients, 55% had a trouble in sleeping, 64% reported that they were easily startled, 82% of reported that it reminds them of having some physical reaction such as sweating, breathing, or trouble trouble or nausea. Now, one of my psychiatric colleagues gave me a very apt description of this kind of an illness. Said that we had one Bhopal tragedy, and the people of Bhopal, even after so many years of passing down, it happened in 1984. Even after so many years, some of the inhabitants of that area, they still have post-traumatic stress disorder. Thousands of people had died and gotten involved with the methyl isocyanate gas in Bhopal in 1984. Imagine one Bhopal tragedy is happening in each city with this pandemic. Thousands of people are dying in each and every city. Your near and dear ones, you have come out of the problem, but when you are listening to the media, you're listening to the social media, you're listening to people like me who are talking to you and telling you that there might be a persistence of symptoms. So you might get a psychological burden. In healthcare workers, it is slightly less, but in patients, insomnia is more, memory impairment is more, and impaired concentration is more. In healthcare workers, post-traumatic distress is evident because healthcare workers involved in managing these patients have seen death and disability, social isolation of the patients, unprecedented, something which they have never witnessed in their entire life. We've covered this. So what can you do? During the admission, you monitor the mental health. We at PGI have a psychiatry consultant of the professor rank working with us, and 1 or 2 psychiatry residents, junior residents and senior residents are posted for 6 to 12 hours in the ward. Their only job is to go talk to the patients, address their psychological problems. You assess they assess the acute distress reaction, support critical care staff for providing psychological first aid, and at places where it is needed, they are using medications. Prior to the discharge, you collate all the information, provide verbal and written information regarding the common psychological reaction, screen, and then re-administer the clinical assessment for acute distress at the time of discharge. We are following them up telephonically, all our patients who were with us at PGI and have been discharged, and we are looking at their various parameters of emotional and psychological distress, and we are following them up for up to 6 months. So these are some tools which can be screening tools which can be used at the time of discharge, and they will help us in following up these patients, whether they've improved or whether they've deteriorated. Mind you, your own experiences coupled with what you hear from your relatives, your near and dear ones, will make a major impact on your psychology when you go back home. Rehabilitation. Most of the patients have physical deconditioning. They've been lying in bed. They have impaired lung function, may have cognitive impairment, may have gut problems. So you need to have a multidisciplinary team. In our follow-up team, we have a psychologist, we have a pulmonary medicine specialist, we have an internist, and we have the nursing personnel who are taking care of these patients, talking to them telephonically every 2 weeks or so for up to 6 weeks, and then at 6 weeks they are supposed to come and physically get themselves examined. Most of them are not coming forward because of the sudden rise or spurt in the cases, but now after the cases have gone down, some of them have opted to come back to us at the hospital for physical examination and better delineation of their disability. So the conclusion is that long-term effects of COVID-19 is still evolving field. We got a letter from ICMR today, which and DGHS, which say that we need to have small projects on follow-up of all COVID patients. And I'll urge, if there are any healthcare workers who are tuned in, that they should try to look at their own discharged and follow-up patients. It's important because you may develop small projects to look at new treatments. You have to understand the mental impact of post-COVID. You have to create tools which help people manage their long-term recovery. And we have to have post-COVID care clinics. At PGI, we have post-COVID care clinics on Monday and Thursday in the outpatient department. You can register online and come and visit. So, ladies and gentlemen, a lot of things which still need to be done. And some of the simplest things which can be done is gradually increasing your walking distance, which is a very good exercise. It helps move your muscles, it helps move your joint, and it helps build up your respiratory or lung capacity. So simple walking initially for, let's say, start with 5 minutes every day, gradually increase by 1 minute every day, and your aim is to have a 30-minute of walk initially at your own pace and later on at a rapid pace, so that your pulse rate also increases by at least 30% of the baseline. That's your goal. So you can do this, and simple walking is a very good exercise upfront. You should always avoid sternus exercises within first 3 to 6 months. Gradually increase your activity. Good nutritious diet is very useful, and vitamin supplements and all other kinds of immune boosting agents are not worth the cost or worth the label which is printed on the bottles in which they are sold. Thank you very much. If there are any questions, I'll take it up from here.
Thank you, sir, for a very nice talk on COVID-19 and its sequelae. I think COVID-19 is still a mystery, and every time it comes, it brings new problems with it, and new it brings uh, management issues and rehabilitation issues. So what we have to do is prevention is better than cure, because that is the only dictum that we have. It is better to prevent COVID-19 by using the various methods of social distancing, mask, and not having public gatherings. So with that, I think we can have the house open to questions. Uh, the first question we have is, apart from psychological issues, what are the physiological reasons for palpitations in post-COVID phase?
Okay, one of the reasons which we've observed is that it's a neurotropic virus and it will cause autonomic dysfunction in very many patients. And now it is very well established that in lots of patients, it causes resting tachycardia, the pulse rate going beyond 100 without any evidence of fever, without any evidence of exertion. So if that kind of a picture is happening, then that you should be forewarned that it could be a manifestation of autonomic dysfunction. And these patients are more prone to develop orthostatic hypotension and orthostatic syncope. So this is the thing which can be one of the important physical signs which can be looked at the time of discharge. Patients who are having resting tachycardia, they can have this kind of a picture. Second is that because of the microcirculatory involvement, this is a thrombotic, COVID-19 is a thrombotic state. So because of the microcirculatory involvement, there could be a demand-supply mismatch also at the microcirculatory level, which may be causing ischemia, which may further precipitate arrhythmia, especially in patients who are diabetics, especially in patients who are hypertensive, and patients who have pre-existing coronary artery disease. So these patients need to be very, very careful. And if they develop any cardiac symptoms, they should go and contact their physician and take their advice for further management.
The next question is from PLV Subbarao. D-dimer level, how many days it's elevated after COVID-19 infection? At what level we have to be?
Forget the D-dimer levels. You know what is happening is that we are getting too many investigations done and we end up with the results which we cannot explain. A D-dimer elevated has got no value in any of the patients. A D-dimer normal in an emergency situation indicates that you can easily rule out pulmonary embolism in a patient who's having breathing difficulty. A positive D-dimer level does not give you anything at all, right? Now, why are we getting D-dimer levels? D-dimer level is also an acute marker of inflammation or marker of acute inflammatory conditions. So that is why it is an indirect marker along with LDH, along with CRP, one of the markers. Initially, there was a lot of hype about D-dimer that if it is elevated or very highly elevated, then we can give a therapeutic anticoagulation to these patients. Now it is conclusively proven that only prophylactic anticoagulation is needed in admitted patients in the hospital. D-dimer levels may be elevated if there is a microcirculatory thrombosis. There are currently 2 trials undergoing in US which are looking at the role of aspirin as an antiplatelet agent in post-COVID recovery phase, whether it prevents any cardiac events or not, or any other kind of beneficial effect on reducing pulmonary embolism and things like that. We still don't have the results, So what my humble request is that do not get unnecessary D-dimers done every 2 weeks post recovery or things like that. It's not needed. If you have a high risk suspicion, patient is having diffuse atherosclerotic disease, patient is having a coronary artery disease, patient is having uncontrolled diabetes, where or a deranged lipid profile, you may give 75 milligrams of aspirin to these patients to prevent any kind of thrombotic complications. Otherwise, I won't recommend getting any D-dimer level in post-COVID syndrome, except if you develop fever and shock. There, you need to get all the inflammatory workup done.
The next question is secondary increase in inflammatory markers with or without fever. What are the chances of secondary infections in them?
Secondary infections in a patient who is hospitalized and is on steroids may not manifest with fever. That's number one. And secondary infections do not occur just with a 4 or 5 days course of steroid. If you are using a very high dose steroid for a prolonged period of time, that is when you end up getting secondary infection, most commonly in hospitalized patients, most commonly in patients where you have used high dose steroids, most commonly in patients where you have used immunomodulatory agents like tocilizumab or baricitinib. These are the conditions where you would end up getting secondary infections. And if the patient is on high dose steroids or drugs like these in the hospital, may or may not mount fever, may or may not mount fever.
Secondary increase in in Jharkhand, we are doing follow-up both home isolated and hospital admitted COVID-19 patients post discharge, and I must say we are encountering lots of mortality and morbidity.
This is something which we were worried about when we looked at our nearly 4,000 patients who were followed up after discharge. And we found that, out of 4,000, nearly 80 patients had died after discharge from the tertiary level COVID hospital, which is run at PGI. But when we went into the details of them, we found that out of these 80, 60% had died at a hospital because they were having either a persistence of symptoms or having persistence of respiratory distress, or had gone on to develop a secondary complication. That is why they were admitted or they were in the hospital. A lot of our patients, as I've already mentioned, that COVID negative status, virological clearance will happen early, but your cardiac inflammation and your respiratory problems may persist for a longer time. Now, this cardiac inflammation can cause severe arrhythmias, coupled with the autonomic dysfunction, which I just talked about. These patients can have sudden cardiac deaths and may, kind of give rise to some mortality. So it's very pertinent at the time of discharge, you record their vitals carefully, you do the ECG carefully, and look at whether there is any persistence of any arrhythmias. You should follow these patients up every week or every couple of weeks to find out whether they are developing new onset symptoms. And if any one of them is developing a new onset symptom, they should report to their nearby hospital. What happens is, because of their previous experience of isolation and kind of stigmatization of COVID, these people do not want to go to the hospital, and that delay in bringing them to the hospital may lead to a sudden death at home.
How much is the risk of stroke post-COVID?
We haven't seen too much of strokes coming in either with COVID or post-COVID. We have seen a lot of patients with acute coronary events, new onset arrhythmias coming up with COVID, and even in post-COVID situation. As I said, that COVID is a prothrombotic stage, and right now there are trials going on which are looking at the utility of low-dose aspirin in preventing post-COVID complications. There were some data earlier which had suggested that you give anticoagulants like rivaroxaban or warfarin on discharge to these patients, which is not a very good practice, because these patients go on to develop bleeding complications because of unsupervised anticoagulant administration. So aspirin is my bet. We still don't have the data on it, but answering your question, we're not seeing too much stroke, but yes, we are seeing a lot of cardiac complications, including MI, in COVID and post-COVID situation.
Sir, how to improve recovery from late parosmia and anosmia in post-COVID patients?
You can't do anything. It's a neurological effect. It will go on its own. If your symptoms of parosmia and are persisting, or anosmia are persisting, you should go meet your ENT people. There is an entity in which your olfactory bulb is known to get damaged because of the COVID infection. If there is a damage there, then it may recover partially or may not recover completely. Most of the time, anosmia, parosmia, and ageusia, or loss of taste, are the symptoms which recover very fast. They recover very fast. They recover within first 7 to 10 days of developing these symptoms. If your symptoms are persisting even after discharge, or even after complete recovery beyond 2 weeks, you need to go and meet your ENT people, because one of the commonest cause of anosmia, parosmia is development of chronic sinusitis, which can happen if you've taken long-term steroids. There could be a sinus infection that would need to be ruled out.
For how many days should we give steroids in case of chronic cough due to fibrosis?
As I said, there is no data. Right now, we are conducting a trial in which after discharge, normally we give steroids for 5 days, which can be extended to up to 10 days. At 10 days, in majority of the patients, we stop. If their oxygen requirement is persistently high, we try giving them low dose steroid that is equivalent to 10 milligrams of prednisolone. And the trial is currently going on, which is looking at the duration, whether 6 weeks therapy is good enough, or we need to give it for 3 months or prolonged. We still don't have the data. Most of the times we have used in our patients from 3 to 6 weeks, low dose 10 milligrams steroid.
Sir, what about mucormycosis?
Yes.
What about mucormycosis?
Yes, a lot of patients, a lot of people ask this question, that rheumatologists, the other specialties have been using low dose steroids for a very long periods of time, and they've never experienced mucormycosis. If you combine mucor is a ubiquitous organism, it will come with breathing and it will lodge up in either your lung, or for that matter, all the fungi, they lodge up in either your sinuses or your lungs. Now you give a high dose steroid for a prolonged period of time along with antibiotics. Now, antibiotics will wipe out your, local flora in the sinuses, in the lung. That local bacterial flora in the gut, in the sinuses, in the lungs is very important to inhibit the unrestricted growth of fungus in any of these organisms. So once you wiped out the flora, normal commensal flora, You have the exposure to the fungus. You have given high dose steroid for a very long time, which causes immunosuppression, causes hyperglycemia, which is like a food to the fungus. फंगस कहाँ ग्रो होती है? फंगस उसी जगह पे ग्रो होती है जो हॉट, ह्यूमिड और जहां पे उसको ग्लूकोज मिलता है. तो आपने स्टेरॉइड से उसको हाइपरग्लाइसीमिया करके ग्लूकोज दे दिया. हॉट एंड ह्यूमिड एनवायरनमेंट कहाँ है? आपके साइनस में है या आपके लंग में है, और उसका बैक्टीरियल फ्लोरा आपने खत्म कर दिया. इसलिए आपको म्यूकर के केसेस ज्यादा मिल रहे हैं in a select group of patients. In PGI, whatever patients we have admitted, we've used the recommended dose of steroids. We haven't used empirical antibiotics, and we've managed the hyperglycemia very strictly with tight sugar control using insulin. अगर आप इन मरीजों को घर पे स्टेरॉइड खिला रहे हैं एंटीबायोटिक के साथ, तो 90% चांसेस हैं कि जो डायबिटिक नहीं भी हैं वो भी डायबिटिक बन जाएंगे, उनकी शुगर हाई हो जाएगी और उनमें सुपर एडेड बैक्टीरियल और फंगल इन्फेक्शन होने के चांसेस बढ़ जाएंगे.
Can acute pericardial effusion, oblique tamponade occur in
No, it's less. It's not. In multi-system inflammatory syndrome, yes, there is a possibility. In acute COVID, it doesn't happen.
What is the workup needed before diagnosing multi-organ inflammatory syndrome?
First is that you need to fit into the criteria. You need to do an RT-PCR, prove that this patient is RT-PCR negative. You have to prove that this person has adequate IgG response, which indicates that the patient has already had an infection in the past. You need to do a whole set of inflammatory biomarkers, which indicate very high inflammatory parameters like CRP, LDH, ferritin, D-dimer, and coupled with shock, high-grade fever, manifestations of gut and CNS involvement, or skin involvement, which is seen in up to 60% of the patient, you make a diagnosis of multi-system inflammatory syndrome. Dr. Neena, can I wind up because I have another session at 4 o'clock?
Yeah, sure, sir. I think we can take
log in. I have to log into another session.
No problem. We can ask the viewers to post their questions in the mail, and we can forward that mail to you later on if it's okay with you.
I think I have covered most of the things. In case there is still something left, we can easily, cover it. I'm so sorry. I have to go because there's another session I'm supposed to log into at 4 o'clock, and they are, calling me up.
No problem, sir. Thank you so much for giving so much of your precious time. I think you have answered all the questions. Thank you so much. Thank you.
Thank you, sir.
With that, I'd like to thank all the participants, and I'd like to thank our team from PGI and our partners, UNFPA and REC, who have helped us to organize this webinar. I think we can tell all the participants, if they have any more questions, they can put them in the chat box, or they can send the mail later on to us, and we'll forward it to Dr. Bhalla, and their queries will be answered. So thank you, everyone.
Thank you.
Kiranjit, you can tell them about the YouTube because many of them wanted to know if they could have the PPT.
Sure. Thank you so much, Dr. Neena, and very well thank to Dr. Ashish Bhalla for giving us his very precious time. He's really busy, and we've been trying to get his dates, and he finally came, and I think that is really good and enriching for our participants. So all these webinars are live telecasted on our YouTube channel. The link is available to you all in the chat box, and also will be available on email IDs. So as the next leg, before going offline, the next leg for our COVID-19 management webinar series is on psychosocial effects of COVID-19 on patients, families, and healthcare personnel, and what are the coping strategies. So this will be taken by a faculty from Psychiatric Department from PGI Chandigarh, most likely next Friday or Saturday. The dates and the login details will be shared with you shortly. Thank you so much, everybody, for having time to join with us. And